Today let's study about celiac disease, also known as gluten enteropathy or celiac sprue. So it is the abnormal small intestinal mucosa due to intestinal reaction to gluten. Gluten is a protein found in wheat, barley, rye, and possibly oats. So, what is the etiology? So, what is the etiology? It is a unique autoimmune disease. So usually happens in the individuals carrying the genetics HLA DQ2 DQ8. So there will be an autoantigen which is tissue transglutaminase, and the environmental trigger is nothing but gluten, which is found in barley, rye, oats, and wheat. We call it as bro. So what actually happens is the gluten is broken down to gliadin. So this gliadin is a toxic protein for these individuals carrying HLA-DQ2 and DQ8. It is more common in females. So it's more common in females. Usually there will be inheritance, like if the first degree relative is affected, like maybe one first degree relative, there is 10% chance of this disease being carried on to the child or the individual. If there are two first degree relatives, there is 20% chance. So it might present at any point of time. It can happen even during infancy. The peak presentation usually will be at infancy. When the cereals are introduced, that is after exclusive breastfeeding of 6 months, when the cereals are introduced, the baby might throw up with profuse diarrhea, might have failure to thrive, etc. So this is about celiac disease. Now let's move on to clinical features. So what are the clinical features? So what happens is, usually the patient might present with diarrhea. It will be usually profuse diarrhea, which causes significant weight loss, nutritional deficiencies, anemia, like because of iron deficiency, symptoms of mineral, vitamin deficiencies, failure to thrive, like in infancy, and bloating, and what else? Or it can also be asymptomatic, The person might not even know that he has celiac disease. This is risky, asymptomatic, because it can't be treated unless the patient presents with signs and symptoms. So the disease usually is restricted to proximal bowel. So as we know, proximal bowel, which consists of duodenum especially, so it's the part where there is absorption of iron, then folic acid and calcium. All these absorptions happens in proximal small bowel. So these deficiencies are more common than vitamin B12 deficiency, because vitamin B12 deficiency happens in the distal bowel. So since celiac disease usually happens in the proximal bowel, so it causes deficiencies of iron, folic acid and calcium more than vitamin B12 deficiency, because vitamin B12 deficiency usually happens in ileum or the distal bowel. So this gluten enteropathy, other than the previously mentioned symptoms, it can also be associated with dermatitis herpetiformis and dermatitis herpetiformis, skin eruptions, epilepsy, then myopathy, then depression, usually happens in females, then paranoia, infertility, bone fractures or metabolic bone diseases, also other autoimmune diseases like type 1 diabetes and thyroid diseases, etc. So these are the other associated diseases along with celiac disease. Now coming to investigations. So we know that it's a disease associated with the antigen tissue transglutamin. It's tissue transglutamin. This is the culprit antigen. So what happens is, when the bro is barley, rye, oats and wheat are introduced into the GI system, the tissue transglutaminase antigen gets activated. Usually what it does is convert gluten into gliadin. So this gliadin is a toxic protein. So this becomes toxic in case of people having this autoimmune disease, which is celiac enteropathy. So there will be the inflammatory reactions. So CD4 cells, CD8 cells T cells get activated. Also there will be formation of antibodies, which is IgA antibody against this TTG antigen. So this causes severe inflammatory reactions in the GI system. If these are the villi, so all the inflammation takes place in the villi, and eventually there will be destruction of the villi and the gut seems flat with no villi because of these all the inflammatory reactions. So what happens is, there will be initial stage, there will be increased intraepithelial lymphocytes, which is the earliest pathologic finding. Is the intraepithelial lymphocytes, which is nothing but CD4, CD8 T cells that come because of the inflammatory reactions. Now, then what happens is there will be crypt hyperplasia. Crypt hyperplasia, that is the next stage of pathophysiology. Crypt hyperplasia usually occurs because of the inflammatory reaction. Then, final stage will be villus atrophy. Villus atrophy. This is the last stage of pathophysiology. It's the last stage. There will be villus atrophy. So there will be villus atrophy, which leads to decreased absorption of the nutrients like iron, folic acid, calcium, etc., leading to decreased absorption and so nutritional deficiencies causing anemia, metabolic, bone diseases, etc. Okay, so this is the pathophysiology. Now, coming to serological tests. What should we find in the serology? So, the person having celiac disease will definitely have anti-TTG antibody in his serum, right? Which is a IgA antibody. Since this antigen, which is TTG antigen, is present in his body, right? So there will be IgA antibody present in the serum. Okay, so this patients, so we'll have to check the IgA antibody presentation in the serum. That is the first test. So it has 90 to 98% sensitivity, 94 to 97% specificity. Okay, now coming to other investigations. So we first go for IgA antibody detection in the serological tests. In some cases, the patient will be having selective IgA deficiency. In patients suffering from selective IgA deficiencies, he will be false negative for TTG, anti-TTG tests. Okay. In such cases, if we suspect selective IgA deficiency, we have to measure serum IgA concomitantly via serum immunoglobulin quantitation tests, etc. Okay, now other serological tests. It's serological tests are done, and then other investigations we can incorporate serum TTG and or DGP IgG in case of IgA deficiencies. So in such cases we can go for serum TTG. Directly we can assess the serum TTG or DGP IgG tests. Okay. Now, also other tests, other investigations include the biopsy, bowel mucosal biopsy. We can do this. Usually duodenum is diagnostic. But in the clinical practice, we usually don't do this because we already have the serum test. So why should we go for riskier interventions? So and duodenal biopsy is like too much. You get it, right? So we don't usually go for bowel mucosal biopsy. We just detect it clinically or through serological tests. Okay, that is bowel mucosal biopsy. Of course, in this bowel mucosal biopsy, you can find the intraepithelial lymphocytes if it is in first stage, or crypt hyperplasia in case of next stage, or villus atrophy in the last stage. So this can happen. Also, for these bowel mucosal biopsy with such features, we have other differential diagnosis like for the villus atrophy part, we have other diagnosis like it happens also in case of Crohn's disease and lymphoma. There will be intraepithelial lymphocytes and giardia infections, HIV infections. Villus atrophy can happen, intraepithelial lymphocytes can happen. So all these things will happen in all of these cases too. So you have to do the proper evaluation. You should relate it with along with the clinical symptoms and signs. Now, also this investigation includes we can counsel the patient to have a gluten-free diet and check. So there will be improvement with the gluten-free diet. If the patient improves with gluten-free diet, we can confirm it to be a celiac disease, right? So that is one of the investigations. And then other things are like CT enterography. CT enterography can be done to visualize small bowel, to rule out lymphoma. If we are suspecting lymphoma in this patient, we can rule out by doing CT enterography. And other investigations like clinically assessing for malabsorptions like localized or generalized nutritional deficiencies, also like these malabsorptions can be evident through steatorrhea due to decreased fat absorptions. There will be increased fat in the stools, so that can cause steatorrhea. And low levels of ferritin or iron saturation, low levels of calcium, low levels of iron, albumin, then cholesterol, then carotene, vitamin B12 in some cases. Usually calcium, iron and folic acid deficiency will occur, as I explained before. And also quantitative fecal fat greater than 7%. So all these are the investigations to detect celiac disease. Coming to the treatment part, so what can we do for these patients as treatment? First thing is dietary counseling. As I mentioned before, since these people are allergic to bro diet, you need to give them dietary counseling. So what will you give as a dietary counseling? Gluten-free diet, of course. Gluten-free diet. Avoid barley, rye, oat and wheats. Okay. Now, other things are acceptable. Just avoid these. You can give them rice, rice and corn flour. All of these things are acceptable. Okay. Also, what else? You need to treat the nutritional deficiencies, right? So, nutritional deficiencies like iron and folic acid, supplementation, even the calcium supplementation has to be done, right? Now, Other vitamins too, if needed, yeah, including folic acid. So all these things are the dietary counseling part. Now, if poor response to dietary change, so you advise the patient to have gluten-free diet, that is avoid barley, rye, oat and wheats, and then you give them supplementation, iron, folic acid supplementation, calcium supplementation, other vitamin supplementation. You give all of that. Still, the patient is not. Uh, Still, the patient is not improving in his symptoms. Then you can actually go for alternate diagnosis. Maybe he is not at all suffering from celiac disease. If he is suffering from celiac disease, definitely he should improve with the dietary counseling. But if not, you have to go for alternate diagnosis. As simple as that. Alternate diagnosis. Okay. Or you might counsel the patient, but will the patient actually follow what you said? That can also be the case, right? So it can also be non-adherence to gluten-free diet. That can also happen, right? The patient is not improving because he is not following your orders. So that can also be the case. Non-adherence. Or there can be other associated diseases like microscopic colitis can be there, or even the pancreatic insufficiencies can be there. Okay. Or the patient can also have intestinal lymphoma. This is the worst case scenario. The enteropathy associated T cell lymphoma can also be there. So you need to be careful, right? If the patient is not improving, it's better to go for CT enterography, because that shows if there is any lymphoma in the gut. So the patient might also have, along with this, the patient might also have significant weight loss, a palpable mass, abdominal pain. So all these symptoms will be there, and this can also be a cause, right? And then the patient might have intestinal ulcerations characterized by aberrant intraepithelial T cell population, which is a precursor to T cell lymphoma. Now, coming to prognosis, this celiac disease is associated with, as I mentioned above, increased risk of T cell lymphoma. Okay, because of the significant inflammation, the T cells get accumulated. The first stage will be the intraepithelial T cells, increased intraepithelial T cells. Then there will be hyperplasia, which might lead to dysplasia, causing T cell lymphoma. This can happen. Okay, and other carcinomas, as I mentioned, the hyperplasia can lead to other carcinomas like small bowel carcinomas, colon carcinomas. So all these, there will be increased risk of T cell lymphoma. Also, other autoimmune diseases, and obviously this risk can be decreased by gluten restriction. So this is about gluten enteropathy. Thank you.